Hi, everyone. Whew. Here we go. Welcome, as Rachel said, welcome, welcome, welcome. I am Jamie Allen Black, the CEO of the Jewish Women's Foundation of New York, and thank you for joining us today. We're going to get going. Welcome you to our ongoing Crown Jewel Conversation series, where you get to learn and interact with our grantee partners. We call them Jewels, Jewish entrepreneurial women, executives, and leaders. Checking to make sure I'm unmuted. I am. These are women who are leading nonprofits addressing today's most pressing issues around the world, in the Jewish community and well beyond. For those of you who don't know us so well, and as a reminder for those who do, JWFNY has granted more than $6 million to over 300 programs to address intractable problems around the world. That nearly 25 years of experience in grant making has led to the work we're doing today. We've expanded and redefined our mission to support visionary Jewish women, social entrepreneurs, and leaders. These leaders are on the front lines of the COVID crisis, supporting women impacted by poverty, mass incarceration, gender violence, and as our guest today, Rachel Zaslow, will tell you, addressing disparities in the healthcare system. Sometimes our program is mistaken as a leadership development or another kind of training opportunity, but what we really offer is leadership acknowledgement and advancement. We're introducing you to cutting-edge feminist leaders. When we think of all of the male CEOs slated to leave their positions in the next 3 to 5 years in the Jewish and secular communities, these are the women you will want to know. When you're looking for Jewish women role models working across sectors, we can introduce you through our expanding network. And these women are the leaders we need right now, and we're proud to elevate their voices. Our conversation today is with Rachel Zaslow, Executive Director of Mother Health International, an organization that provides relief to pregnant women and children in areas impacted by war, natural disaster, and extreme poverty. They create sustainable, culturally competent birth centers where women can care for one another and support each other's healthcare needs. Rachel will share with us how she creates community-driven change by building infrastructure where local women can then lead. We offer these sessions at no cost to you, but if you find value in what we're doing, we hope you'll consider 2 donations. One to Mother Health International directly to Rachel so she can continue her invaluable work. And then also please consider matching that donation with one to JWFNY because we are the only organization providing these visionary, innovative, entrepreneurial leaders with a platform to broaden and deepen their base of knowledge and support. We'll put all the links in the chat and in your follow-up email tomorrow. During the session, if you have questions, put those in the chat. We'll do our best to get to all of them. You've been muted to avoid background noise, so the chat feature is the best way to talk to each other and get your message seen. And now, I am thrilled to introduce my partner, the president of the Jewish Women's Foundation of New York, Rachel Weinstein.
Thank you, Jamie, and welcome again, everyone. So glad you could be with us, and I hope you had a nice Thanksgiving holiday. Hello, Rachel. I feel like we should call this the Rachel Show. I'm really excited to talk to you today about the work that you're doing, and we're just going to jump in. You know, I'd love for you to share with us a bit about what led you to this work. And what led you to Uganda, and then, you know, ultimately, what led you to creating Mother Health International?
That's a good place to start. I always say that I think you can't really find one starting point of an origin story because it's like a long, twisty, rhizomatic entry point. But as the daughter of a storyteller, you always have to start somewhere. So, one of the things that brought me to Uganda, I'm a midwife, and my interest has always been in the way that people understand their own narratives of health in relationship to larger health systems. And so I came to Uganda to work in a government-funded hospital at the end of the 23-year-long civil war there. And when I got there, what I found was some of the things that you'll find across the board in hospitals where there's under-resourcing, there's a lot of overcrowding. And then I was also seeing people giving birth after 23 years of war. So with a lot of trauma that had been enacted upon women's bodies. So women had been abducted systemically and forced to become sex slaves, honestly, so that they could produce children that would become child soldiers. And so a lot of trauma, and that was meeting up against this sort of hospital system that was trying to function like a Western medicine system, but didn't have the resources, didn't have the kinds of things in place that make Western hospitals work well, and sometimes not work well, right? We have problems with our hospital systems here too. So at that time, I was doing a lot as an outsider to try and change the system. And it was sort of like butting heads with like a bull, like as a one person, as an outsider, seeing things that might make a difference, but not being able to do anything because the system was so much larger than me. And some of the most powerful moments in my work there, I would see women come in from the village and bring a woman to the hospital for care and then kind of hide out in the corner. And we were very understaffed, and it was kind of all hands on deck situation. And what I realized is that these were traditional midwives. These were midwives who worked in their communities, but I started researching and had not realized how disenfranchised they were. The government had made them illegal. And yet they were still delivering 80% of the babies in actually the rural global south, not just Uganda, but in the community that I was in, they were still delivering 80% of the babies. And yet they were being told, you're dangerous, your knowledge, because you haven't been through nursing school, is not good enough. And so you need to get women to the hospitals. But the hospitals were overcrowded, dangerous, violent places. And so they were sort of up against this, like also this system that wasn't working, where they were being forced to deliver 80% of the babies, mostly because of distance to hospitals, but they had no support. And so the two hands weren't talking to each other. And I realized that instead of pushing up against a system that wasn't working, one thing I could do was create another model and show another way, right? So instead of pushing up against what's not working, maybe finding another model. And to me, that started with just listening to the traditional midwives and trying to gather their stories and understand what they actually needed and what their unique challenges were. And so that sort of planted the seeds for what is now this birth center in Northern Uganda and ultimately Mother Health International.
Fascinating. And can you share with us, what were some of those needs and what, give us a bit of the landscape. What does maternal health look like and infant mortality in Uganda, or at least at that time? And sort of, what did you see the needs, and then how did you go about sort of addressing that?
Yeah. So in Northern Uganda, so those of you who have been in rural places can imagine dirt roads, long distances from hospitals. But now imagine no running water. People are subsistence-based farmers. And what that means is that you're not going out to work. You are living on what you grow on your land. And that is what sustains your family. And so if you have a good crop one year, things are good. And if you have a bad crop one year, things are bad. And it means you don't actually have cash. So people will live on $1 or $2, maybe a week. Entire families will live on that amount of cash. Maybe you sell a little bit of what you grow, but mostly things are done in trade. And what that looks like in terms of a maternal health landscape is that paying for transport to a hospital can be extremely hard if you actually have to pay in cash money. And if you are 20 miles from a health center. So that's one really big barrier. Another barrier is just that people have different ways of understanding the world. So we understand that Western medicine, like most of us, believe in science as sort of the truth of how we should be approaching medicine. I mean, I believe in science, and I hope
most of us, right?
Understanding that science is one lens through which to view the world.
Right.
And so if you live in a community where the way that you understand your relationship to the earth and the sky and people dying and people being born is actually through narratives, and through stories and through what has come before, sort of a folkloric passing down of this is the way that things are. We do that too. We just don't think about it. I mean, YouTube is folklore, right? We gather information from the internet in ways that inform our way of understanding the world. And but what that means in terms of healthcare is that when you then go to these Western hospitals, which are set up in the rural global South as a result of colonization, right? As a result of coming in and saying, we're British and we're going to take over the resources of this land, but we're also going to give you schools and hospitals. But people don't necessarily have a trust in those hospitals, and for good reason. And so going to those hospitals can often be quite dangerous because you're given information about how to treat yourself or how to care for yourself that is very different than the way that you understand your body in relationship to the world. And so you end up, again, having these kind of two opposing systems. And instead of saying, this is who our community is, and this is how we will treat them and how we can integrate science in, often you just go into this whole other world where, we all kind of know, I hope that race is a construct, and race is very much a Western concept. So you don't have necessarily a race issue in Uganda, but you have a class issue. You have a tribe issue. You have though people working at the hospital have been through some sort of nursing program, that means they can read, they can write, and they will definitely think that they are smarter and better because of class and privilege than the poor people coming in. And so often people experience abuse in the hospitals. So it's layer upon layer. And so living in these rural communities, living far from hospitals where you maybe would have to spend your last dollar to get there, people do deliver their babies at home a lot. But then with mounting pressure from healthcare systems and ministries of health to get to hospitals. And then people's experience when they get to those hospitals is that they're overcrowded, they are yelled at and abused and demeaned, and they often can't even afford the medicine that they might need. Or there's a policy at the hospital where if you come in to have your baby, you have to bring your own piece of plastic to put down on the bed. But if you don't have it, they'll make you leave. And so if you can't afford to buy that piece of plastic, you're not going to spend your last dollar to get there, only to be what they call chased away, only to be sent away and deliver your baby all by yourself. So it makes a lot of sense that people go to traditional midwives. And traditional midwives are the people who have learned midwifery as it has been handed down to them. So many of them don't read or write. Many of them have gotten their information about how to deliver babies from watching their grandmother do it, watching their aunties do it, or from just being sort of thrown into situations. A lot of people were held in captivity for many years in Northern Uganda, and where do you go when somebody's having a baby? You just go to the woman next to you, right? And maybe that person has had 5 babies and she knows a few things because this thing helped her. And so information gets passed down in those kinds of ways. And so because they've learned midwifery folklorically, there's no way to sort of streamline what they know. You might have one midwife who's very competent and one midwife who's just kind of doing whatever she feels like. And so that landscape can be quite dangerous. And so there have been efforts from nonprofit organizations and missionary organizations around the world to try and streamline the information that traditional midwives have. And that's also been sort of a failure on many levels, because often they will eradicate a practice and say, you are dangerous, you shouldn't be practicing, but they're not replacing it with something that is sustainable. So one of the things that happened when I first came to Northern Uganda and did a lot of listening was started saying, like, what are the needs in the community? And again and again and again, traditional midwives are saying, we need a place where we can practice. We are the trusted community members. We are the people in the community that people come to, but we can't work within this system. And how do we form another system? And the answer previously had been organizations will raise money for things like mama kits. Like, let's give traditional midwives supplies that they need. And what I have learned about nonprofit work in the developing world, I will say, although I think that word is problematic. But what I have learned about is that one of the things that we do is we often come in and we think, oh, this is a solution, right? There's a problem. I'm going to hit it head on with that one solution. And so school doesn't have power. Let's fundraise and let's make an organization where we give them generators, because that's how they'll get power. Of course, it's a much larger structural issue. And when you just bring in generators, what can often happen is that suddenly the generators need fuel. And so to fund the fuel, school fees are going to get raised and suddenly kids can't afford to go to school. But in the nice grant report, you say, oh, we put in 50 generators and we serve 10,000 kids and they have power. So thinking about unintended consequences, that happens all the time in medicine. So we have midwives who were cutting umbilical cords with straw grass. And they would go to these workshops, traditional midwives would go to these workshops and be told, nope, that's not sterile. You need to use, sterile scissors or a razor blade. And what we found again and again was that they would then get maybe 10 kits that have sterile scissors or a razor blade and then have 15 deliveries in that month. And then what do they use? They reuse the razor blade or the scissors, and it's not sterile, whereas the straw grass, which they were originally using, actually is sterilized by the sun, is quite sharp, and really is a renewable resource. And so sometimes replacing a technology with a Western technology is not necessarily better. And so those are the kinds of things we started to think about when we built Mother Health International and when we built this birth center, is how do we actually listen to the needs of the community and build systems that work for the community, not just because they work somewhere else.
That's really interesting. It's sort of about elevating maternal health within and birthing within the village itself, right? I mean, is that
in the community where you are. So
right.
This kind of lens can be applied to anywhere in the world. I wouldn't walk into New York City and say, this is how you need to give birth because this is how it works in Uganda. Right. And I wouldn't walk into Uganda and say, this is how you need to give birth because that's how they're doing it over at NYU. Right. So, yeah.
And so what are some of the other sort of distinguishing things that Mother Health International has been doing that sort of differentiate you, let's say, from those other missionary organizations that are going in and trying to do this? What would you say?
So an important element for us has been to think about how people work together. So it's not that one way of knowing is better than another, but that actually we are stronger when we all can contribute what we know. And then we have this sort of pot of information with which to draw what works. Because one thing that any medical practitioner knows is that no two cases are the same. And we always need to draw from different bits of experience. And we can't work in isolated systems. We have to work interprofessionally. And a really healthy functioning healthcare system would have nurses talking to doctors, doctors talking to acupuncturists, right? We would all be in some sort of communication surrounding the client or the patient with exactly what they need. And so we have tried to model that in our birth center. And part of what that has meant has been bringing in traditional midwives who have been made illegal and saying your knowledge is valuable here, and you're going to work alongside nurse midwives and doctors and other people so that we can all work together. And part of the way that we've done that is to bring midwives into the creation of our protocols. And we're saying, you are really the experts in your community. You are the experts in knowing what women in this area of Northern Uganda really need in terms of support. It can't be me. It can't even be a doctor from the big city in Uganda because they're actually from a completely different background, and even if they are Ugandan. And so as sort of experts in your own micro community, how do we draw you in and how do we build protocols? And one of the things that we hit up against was that a lot of our traditional midwives are illiterate. They did not learn to read, write, or count in a classroom. And so we tend to think of illiteracy as a barrier to text. And I sort of started rethinking like, well, what is text? Does text have to be written? And if you don't read or write, how do you pass on narratives? How do you pass on information? And that is through storytelling. And that is through song and dance. So I'm going to share a little video here and you'll hear me talking over it. So I'm not going to explain too much about how we have developed some of our protocols. Let's see here if this works. So
the majority of our traditional midwives are illiterate. They've not learned to read or write or count. And so traditional trainings where you ask midwives to come and sit and learn from something that's written down or a book does not end up being an effective tool. Even images don't end up being an effective tool. But traditional methods for remembering information when you cannot read or write is often through song and dance. So our collective records almost all of our protocols in song and dance, and the song and dance becomes the text. So we have songs here at the clinic for what to do if a woman is bleeding too much. We have songs for how to remember and what the signs are for a woman if she's dehydrated. We have songs for comfort measures in labor, how to make a mother feel more comfortable when she's in labor. We have songs for when to call and come to the health center. So each of our protocols is in a song, and this becomes sort of the backbone of our teachings and how the traditional midwives then carry on about their work. So I think recognizing and placing value on traditional methods of learning is really essential to the work that we're doing.
Okay, I just have to say, as a theater producer in my day job, when I'm not at JWFNY, I love this idea. I love this idea of how you're using the arts and song and dance as education, right? And as training. I mean, that's amazing. How did that come to you that way?
I think it's, you know, it's a lot of things. It's not that it came to me, it's that I asked. So how, if you're not the way that I was taught to learn information, was to sit down at a desk and read information, right? We have literally been, I remember when I started grad school and they're like, oh, you're in an interdisciplinary PhD program. We have all been disciplined into a way of learning and knowing. And so it is easiest for me to interpret knowledge when it is given to me in written form, because that's how I've been since I was 5 years old, trained. And yet, if the way that you have been trained has been through the sharing of stories or songs and dance, right? I mean, traditionally, songs have been the way we record information. That's why songs are ancient, right? That's why songs predate actual written text. That's why we have melodies when we chant Torah that we know are ancient melodies, because they've been passed down from generation to generation to generation. And it's a way of interpreting and understanding the world around us. It's also, I mean, from like a, you know, memory perspective,
Right.
it is how we remember things. I always say,
I was
like,
just
I
about to say that.
remember learning the states in 7th grade and or the countries around the world and all of their capitals via a song, and I still remember it now because it was in a song. And so we commit those things to memory in a different kind of way. So that is science, right? That's science. That's peer-reviewed evidence we can talk about, but at the same time, it's actually just what people do. And so science is a lens also to just understand how people behave and are in the world. And so that becomes sort of the baseline for how we run our birth center. Our birth center centers the traditional midwives. I always think about in justice work, part of the way that we do the work is to center the most oppressed. So anytime you're coming into a situation, you say, who is the most vulnerable? And if we center the person that is most vulnerable, then, and we take care of that person, then by extension, everyone else is taken care of. And, you know, in the West, we kind of do it the other way, where we often center the most powerful and we think about trickle down, and that we know that that doesn't work. And so, in doing that, in centering the traditional midwives as the core of our medical practice, The nurse midwives surround the traditional midwives. The doctors surround the nurse midwives. The larger infrastructure, we have a medical advisory board, surrounds that team, and as an extension, at the very center of that are the mothers and the babies. And those people are the most centered because the person directly wrapped around her is her traditional midwife. And her traditional midwife is the person that she trusts. It's the person that can interpret the world around her in a way that she understands and is made meaningful. It's not me coming in as an outsider and saying, you need to take these vitamins because you're lacking in iron, when I don't understand necessarily her food insecurity. Whereas a traditional midwife can actually say, you know, this food that you grow in your garden is really good, and this thing is not so good, but let's try and increase some of that, and it's going to help a mom have a better sort of prenatal nutrition experience. The other thing that we've done is recognizing that it is really not one thing that creates bad outcomes in any healthcare system, but in thinking about maternal health specifically, we can't say it's one thing. If it was, we'd take care of it, right? It is so many differing factors that contribute to bad outcomes. And so when I look at our little community in Northern Uganda, I can say, okay, we know there are some really big barriers to healthcare. And there was a great article, I always talk about it, published in 1994, but it talks about 3 delays. And the 3 delays are what actually keep people from getting care. And so our entire birth center is focused around addressing the delays that keep people from getting care. So that first delay is the delay in a decision to go for care. So if I am pregnant anywhere in the world and I have a headache, I'm not necessarily going to run to the hospital because I have a headache. But if I can pick up my phone and call my doctor and say, oh, you know, try these things, and if not, come in, I want to check your blood pressure, that's one thing. If I have to actually spend my last dollar to take a motorcycle 15 miles to wait in a line and maybe get turned away, I'm not going to do it. And so we have a labor line. We have a mobile midwifery clinic where we send midwives on motorcycles into the community to meet with traditional midwives and nurse midwives for a collective experience of prenatal care in women's homes. Again, if I have to trade walking to gather water for the day or prenatal care, I'm going to choose water for my family because that's the most pressing issue. And we all make those trade-offs every day. Even the richest among us make trade-offs every day. But if it comes down to water or healthcare, I pick water because that's the more critical thing. And so we bring midwives to women. We bring women to our birth center in labor, and we drive them home postpartum because some of those big barriers are actually just distance, money, and they delay the decision to get care, the decision to reach care, and then the decision, and then getting the care once you reach the facility. And so we really follow all of those things. And ultimately, our outcomes are radically different than the rest of the country. So Northern Uganda has an infant mortality rate of 64 out of 1,000. And at our clinic, consistently for the last 10 years, it's been 11 out of 1,000. And I think I've talked about this to some of you who have been to my talks with you guys before. That is lower than what it is for Black women in America. And for Black women in America, it's about 18 out of 1,000. And for white women, it's about 9 out of 1,000. And so what's interesting to me about that is that the same lens can be applied, right? We're thinking about these barriers in care for women in Northern Uganda, but the same barriers exist for Black and brown women. And sometimes it actually in America, and sometimes it comes down to having your most trusted person around you. So only 5% of doctors in America are Black. And so if we understand how implicit bias works and how these kinds of things impact healthcare, that is what is actually driving these divisions and these gaps in care in the US. And so I think about that too in terms of a larger global framework and how we address programs.
Well, and I think you said a key thing that, you know, the underpinning to all of it is trust.
Right.
And so, you know, as someone asked in the chat as well, it'd be really interesting you obviously also had to go in, whether or not you were spending time there, you were an outsider coming in, you were Western trained, you do have medical experience, How did you gain the trust of these traditional midwives? And then how did you gain the trust of the medical professionals in Uganda to say, you know what, no, we have to trust them and you need to come along with me and you need to help me meet them in the middle? How did you gain trust on both sides?
So I think all trust is built through relationship ultimately and over time. None of this can happen instantly. That's why I always I'm like, don't go on a 3-week medical mission. Don't go help somewhere for 3 weeks, because that's not relationship building. That's you coming in and saying, I'm going to help somewhere because I think I can. And instead, it actually involves vulnerability. It involves relationships that acknowledge power imbalances. So as a Westerner, when I come in, I know that my presence could potentially always be a violence. And I have to be aware of that. I have to be aware of the fact that I have a plane ticket out of there means that I have a privilege that is even just in terms of safety. So there are layers upon layers of things that we have to work through. But at the same time, when you live in a community with people, when you learn the language, when I breastfed my baby alongside women breastfeeding their babies, sitting in circles. And I think that approach, I've always thought about my work as feminist work. And I think when we think about what is feminist work, we have to actually dismantle this notion of a patriarchy. And in order to do that, it can't be top-down modeled organizations. It has to be all of us sitting in a circle. And I think about what all of us sitting in a circle together looks like. And what do women do? We sit around, we have our kids, they all play, we all take care of each other. And that's how we actually get work done, because we remove some of the barriers of the day-to-day domestic work when we sit together and we team up. And so part of that is actually just over the years, sitting, listening, building trust, bringing my child into the community, learning the language. And really, really, I think over time, following through on your word. So we're going to build a birth center, and then actually doing that. I remember it's in the first year, somebody had donated us 100 bicycles. And it was so exciting because we were going to get these bicycles and they were being shipped over on a shipping container, and the midwives really needed them to get out into the community. And then they got held up in customs at this, and it was the rate that they were charging us per day. It was going to be $30,000 to get these bikes out of customs, and they were donated used bikes. And so there was no way we were paying that. And I had to sort of go back and say, I'm really sorry. And when I tell you, people didn't let me live that down for 5 years. People were we're still waiting on those bikes. I'm you guys. So we were having this kind of they couldn't understand what customs and this, they just knew that I had said, we're bringing bikes. And I was so excited. And eventually we did get bikes. But we bought them locally. And so, there are so many layers to it. And in terms of building trust with the government, we have, again, it's about relationship. We have a really close relationship with the district health officer, who is the representative for the Ministry of Health. We make him look good. Our outcomes are really good. So also recognizing that it's reciprocal, but also I've done my due diligence. I sit on a maternal health review board with the Ministry of Health in Uganda. So every time I'm there, I spend several days sitting in these meetings in Uganda and Kampala, and just putting in time as and contributions to the Ministry of Health's task force as well, so that we have relationships. And when I need to call somebody in for support, I can.
Well, that segues into a few of the questions that are in the chat, which I have a couple of them that I want to get out to you. First of all, do you see a lot of younger women training to become midwives, traditional midwives? Is that still happening, or
so yes,
more because
we started at 30 traditional midwives, and we expanded to 60 because at some point we realized that a lot of them were getting older and were tired. And so we asked them each to pick an apprentice in their community. And so each of them has a younger apprentice. So that's the traditional midwife. And at some point, those apprentices will pick an apprentice, right? And it will. And also, I've spent a lot of time talking about traditional midwives, but we also do a lot of training of nurse midwives now. And so I'm on clinical faculty at Makerere University and at Yale University. And part of what we do is we have a partnership, and we are bringing in nurse midwives for training and for clinical placement at our birth center. And that is mostly young women. And one of my big goals this year, and something we were really working towards before COVID, is to actually build a birth center not a birth center, a midwifery school adjacent to our birth center, because I want to train nurse midwives in our model from the very beginning, so that they don't come to us and have to unlearn some of the things that they've learned in nursing school, which follow sort of more of the culture of violence in hospital systems in Northern Uganda. And I want them to learn gentle birth and normal birth and midwifery model of care from the beginning.
Interesting. What happens when there's a complicated delivery in one of your clinics? Are you then taking women to the hospital? Are you bringing doctors ever to your clinic for when you need them?
So we can handle most complications with our incredibly skilled nurse midwives and some doctors who are on our staff. But one is that a lot of preventing complications, or a lot of complication is about prevention, I should say. So having really good prenatal care can help us assess if something is going to be a high risk birth. We know if somebody's anemic and is more likely to bleed out. We know if somebody's carrying twins. We know if somebody's baby is breech if we've seen them prenatally. And so we're able to then follow those women more closely and make sure that they are where they need to be to give birth. We can handle those kinds of deliveries. We do breech deliveries, we do twins, we've done triplets, we can handle a hemorrhage. We have everything you need for most births. But when someone needs a C-section, we do transfer them. And the closest hospital is 75 kilometers away. It used to be on an unpaved road that was so bad. I'm going to say this. I called it Two Bra Road because you just really needed two bras. It bounced so much. So it used to take us 3.5 hours to get to that hospital. And so during some emergencies, it really was, I remember feeling as we would go down that road for 3.5 hours, as I had a woman who just desperately needed a C-section, going, roads are a human rights issue. Like, how can it be that it's going to take us 4 hours to reach this hospital that's going to be overcrowded, and it's going to take maybe 6 hours for this person to get the C-section. And now it has been paved. And so now it takes us 45 minutes to an hour to fly down that road. And we have relationships with the hospital. So we call ahead and they know we're coming. And hopefully we'll have a room ready for us to just take the woman immediately into a C-section. So again, most of our C-sections are not emergencies. It's something that we do because we know, okay, this looks like an obstruction. We know this baby isn't coming, and we want to do the C-section before it becomes an emergency. And so it's actually very rare that we are like emergently transporting somebody. We are a high volume birth center. We do about 3 to 7 births in a day. And so because of that, we do have every day some kind of complication come up, and a couple times a week we're transporting people to the hospital. The other thing we transport for is sick babies. So sometimes we'll have a baby come in that just needs a little bit more care than we can offer. And so we get them to the NICU at the hospital.
Right. Someone asked, is it possible to train nurse midwives to do C-sections?
It is possible, and there are some organizations that do that training. We've been building some other buildings outside of our birth center this year and had to pause because of COVID, but we were near completion. We're getting our plumbing and wiring for electric in now. So we have 3 new buildings that we built last year behind our birth center, and one of them will be what we call an operating theater. Like, we can actually make it sterile. The problem is, when you're doing a C-section like that, if you don't have an anesthesiologist on call, you end up needing to give them an anesthesia that just completely knocks them out in order to do it. And it's not ideal. So because we have a hospital that's an hour away, most of the time we're going to try and get to that hospital where there's an anesthesiologist. And because most of our C-sections, we know we have many hours before it's an actual emergency, it's better that we just have a working car.
Yeah, I totally hear you. Do you offer any postpartum support to mothers?
Yeah. So our mobile clinic, so we keep women for 24 to 48 hours. So we do the immediate postpartum at the clinic, whereas in a typical Ugandan hospital, you're actually discharged about 3 hours after you give birth, and not really given any follow-up. So we keep people 24 to 48 hours and longer if the mom or baby are not doing well. We've had women stay with us for up to a month if the baby's too small or anything like that. And then we also follow them. So because we have such close relationships, the traditional midwives know who every person in her community is that's pregnant, we've had at least 9 prenatal visits with them. We've done the birth, and then we do at least 6 postpartum visits in her home. And so our mobile midwives program brings people into their homes. And so we're tracking people at least for 3 months and usually up through the first year.
And you mentioned COVID a couple minutes ago. How has COVID impacted your work?
Well, it's been an interesting year in a lot of ways. Obviously, birth doesn't stop and the need for healthcare doesn't stop. And so we have changed a lot of our protocols. Our birth center really doubles as a community center. So pre-COVID days, in the center, we have a big center room with hammocks, and you would just find people hanging out, like people for prenatals, and they'll take a nap. And I always love that people take a nap after their prenatal because they're like, oh yeah, I was waiting in a long queue. I couldn't make it back to cook dinner tonight, but really they're taking a nap, and I need that nap to happen for them. But there's often also like somebody's in labor and 6 family members are sitting outside and there's meals being shared and there's a lot of activity going on. We have classes, people are waiting for prenatal care, lots of things are happening. It's like a hustle and bustle kind of space. Now we have cleared it out so that it's only women in labor in the birth center. All of our prenatals are happening outside in people's homes. And so we're not having crowds of people. So we have had to sort of reimagine how we do things in order to, not have crowds of people come together. But at the same time, our numbers have actually gone up in terms of like the number of women that we're serving this year. So, it's just been about reimagining how to do things.
We have so many questions. I'm going to try and plow through them because we're like running out of time. So I'm going to combine them. Is there any fee for service, or are your services free? And how ultimately are you sustaining yourself as an organization in terms of where's most of your funding coming from? Is it from individuals, foundations? Are you getting money from the Ugandan government?
All of the above. So we do not charge for our services. When we first started, people were living in internally displaced persons camps, and asking for any amount of money would have been too much. And we've tried different models before. We've done work exchange programs where we say, if you work on a beading collective with us and we sell the beads, then you get care. We've tried lots of different models and we still have some of those things in place. But the way that we do things now, I was listening to NPR one day and I was listening to, the like everybody donate campaign that they come in with, like everybody gives $1 and then everybody gets to listen to radio. And I thought, I wonder if we could do that in our community. Like, could we hire, I call them the NPR ladies. Could we hire some NPR ladies who are in our community to walk around and say, can you give $1? And if you give $1, everybody will get free healthcare. And so we have like a community stakeholder program where people go twice a year and ask for people to give their $1. You don't have to be a woman giving birth. It could just like, are you a man in the community who has a sister who gave birth, or a wife, or a mother? So then you are a stakeholder. We have a once a year annual stakeholders meeting where anyone is welcome to come because they are co-owners of the clinic. And so we collect between $30,000 and $50,000 a year in $1 community donations. And that drives a lot of our actual, like our need for supplies and things like that. What it doesn't cover are things like our ambulance that fuel just costs a lot. Maintaining vehicles costs a lot. And some of the salaries for our more skilled, like our nurse midwives and doctors who have a higher salary. And so that's where we do lean a lot on foundation support, grant support, individual donors, fundraising events, community events, and we really do bring in money from sort of all over. And we do, in terms of government support, in theory, we're supposed to get a lot of supplies for the government, but that does not always happen.
And just to clarify for our listeners, you're splitting your time between Uganda and the
Back
US?
and forth, yes.
Yeah, that's busy as well. Where would you like to see your organization go from here?
So, you know, this larger vision that I have of sort of micro health systems spiraling out into the macro. So if we can look at each community and say, what are the unique needs and barriers in this community, and do wraparound care. So thinking about the mom and the baby, and then who is around her, and who is around that team, and who is around that team, and who is around that team, that model for care can really be placed anywhere. And so for a long time, I felt sort of paralyzed when anyone would ask me that question, because I'm like, well, I don't know, like if you were to give me $20 million and I say, let's put a bunch more birth centers up, but who would sustain those birth centers? How do we do that? And how do we make it? I mean, yes, there is that vision, but ultimately people need to be trained in our model. And so the next step is building this midwifery school where people can really learn our model and working from an education standpoint so that people can understand it. And then if they want to go work anywhere in the world, they have the model to carry forward.
Wow. I mean, I hope so, because it's a fabulous model. And I'm wondering, and someone's wondering from the chat, is there someone or something that inspired you to sort of lead into this work and to build this model for others to follow?
I love women. People always say, you know, as a midwife, you must love babies. I'm like, well, yeah, babies are cute, but I actually have very little to do with the baby. If I'm doing my job right, the baby goes right on the mom and I'm not really dealing with the baby so much. It's women.
And I guess this will be my last question for you. You know, you've just now completed your first year, your year as part of our collective at the Jewish Women's Foundation of New York. And, you know, you've had your full year. I'm sort of wondering, how has being part of the collective impacted your leadership?
I think one thing that's really interesting about running a small nonprofit is that often it can feel like you're working in kind of like a silo, like this is my lane and that's this person's lane. And as I was saying before, like interprofessional work, I really think makes the world run. So being able to work alongside a group of women doing really interesting, powerful, smart work in the world, and you know, you don't even really realize what kind of interprofessional support you need until you start talking to other people and laying out what's going on for you, and having other lenses and perspectives has been invaluable. So I'm really grateful to have been brought into the space and to be able to just be in community with all of you guys. It's been powerful, and I look forward to sort of seeing how that has a ripple effect over time too.
Well, and we're very grateful to you for bringing us such awareness about this work, for the work that you are doing. You are deeply inspiring all of us, and we're really proud to be supporting you. So thank you. I guess I lied about the last question, because I should have asked you, for people who are listening who might want to do something or get more involved, are there things that you would recommend? What would be some action items for people?
I have some action items.
Oh, go ahead, Jamie.
Rachel already gave us her action items, so I'm going to just move us along since it's 5 minutes. Is that okay, Rachel? Rachel? Okay, good. So I love women too. Thank you so much, Rachel Zaslow, for taking the time to share your wisdom and your extraordinary story with us. And thank you, Rachel Weinstein, for leading us through this great conversation. Wow, thanks for teaching us about listening to stakeholders and working in partnership with them to help create those models of change that address their needs, not what we want them to have. We could use that example in every aspect of our lives. And now let's get that midwifery school built and up and running. We're so inspired by your leadership, Rachel, and Mother Health International's work. And everybody, we like to leave you with a few actions you can take. So first, by directly supporting Mother Health International, you join Rachel in creating a world where women are in charge of their own health care. Just $50 supports one woman's entire pregnancy and birth experience. $50. Second, Mother Health International also needs baby clothes and cloth diapers. So if you wanted to organize a drive in your community, reach out to info@motherhealthinternational.org and they will, and they will help you get started. And third, tomorrow you'll receive a link in your emails to follow Mother Health International on social media. Share the video that will be in that email with other people so that they know about Rachel's work because it's so extraordinary. And so those are 3 actions you can take, and you can take them all tomorrow or now. We hope we'll see everybody at our next Crown Jewel conversation with Dr. Mazal Shaul, Executive Director of We Power. Mazal promotes and trains women to seek public and political leadership positions and works toward gender equity in Israel. Mark your calendars for noon on Thursday, January 7th. We'll send you a link to register for that. Thank you to both of our Rachels. Thank you all for being with us today. We'll see you soon. Have a good afternoon, a Hanukkah filled with bright lights, love, and latkes, and a peace-filled secular New Year for all of us. Thanks.